like to invite the moderators up to the stage. Dr. Spruyt, Pat Hanbury, Les Matthews, Dr. Julie Petrie Thomas, Dr. Wendy Hall, Jen Gardner, and Osman. You're on the panel. Actually, the first question is directed, I believe, at you. We've had a request from a couple of people that are attending the webinar that if people could speak loudly and directly into the microphones, people are having a little bit of trouble hearing, just to help out those that are joining us via the web. Oh, I don't think we have a formal seating arrangement. No, there's not an order. But we do have 2 questions from the audience already. And perhaps we can start addressing those and then we'll move towards the 3 themes that we discussed earlier. The first question comes from, sorry, I'll just wait until I can read it again. For families supporting children in foster care, and specifically with FASD, and I'm looking at you, Dr. Ipsiroglu. We touched on this a little bit yesterday, but perhaps we could go into a little bit more detail, is how at the community level, when you're not a professional, how are community members like foster parents to screen? So could you speak a little bit to that, about the perhaps bears and other tools that could be used to screen at the community level?
So thank you for this question. We will suggest to use this BEARS app. Unfortunately, we have just the prototype. So we have posted the BEARS concept on our website. And I think, Duncan, do we have outside the bookmarks?
The bookmarks of the
BEARS questionnaire?
Yeah, they're in
there. So the key questions are on a bookmark. The key questions are bedtime, awakening, bears, bedtime, excessive daytime behaviors, awakenings, regularity, sleep disordered breathing, and best case scenarios. To what degree does it affect the well-being of your child in order to ground the questions, the scenarios, the answers actually, not the questions but the answers, and is sleep restorative or not restorative. And with that and collected information of 2 weeks, again a log and diary is on the website, I assume, and if not, it will be on Monday. We are sometimes a little bit delayed in our work, not because we are men and can't multitask, but we are a little bit overwhelmed with all the clinical work we have to do. But I promise you that it will be on Monday on the website. And actually, I received this question, which came yesterday too from a parent with an ASD. It is the same answer. We don't differentiate between kids who have this or who have that. It's about assessing. The concept is a generic screening concept based on it.
Is there a variation between pre-adolescence and adolescent sleep behavior and other behaviors, like as it relates to this app, or can you use it across the broad spectrum?
The question goes for those who are following us via the webinars, is a difference in the behaviors between pre-adolescents and adolescents, younger children, of course, but it is still the same concept. We can use it, the same concept also in adults, and you can test it on yourself to what degree it works or not. Given the age, certain things in the interpretation will be seen as normal, and certain things will be not seen as normal. And that's the answer. Thank you. I think I responded to my question, so I can go down.
There's another.
Would you like to come and use the microphone? That would help the listeners
Is it set really low?
not to hear all the time my terrible accent. And I hear you have a British accent, so that will be a delight for the people on the webinar.
My question is that filling out a questionnaire about sleep is a very exciting thing for a parent to do, I believe, because it gives them a picture of what the status of their child. And your suggestion is that they can then take it to a professional, such as their GP. From there, my own experience has been that a GP is looking for someone to refer to on this particular topic, and maybe they might refer to their pediatrician if it's a child. And the pediatrician is then going to look for someone to refer to because their expertise is not in sleep. And that's my big question mark. Where does this go to? Because you're producing work which has potential solution, but is there a pathway towards that solution at that time? In other words, like everything else, is there a sleep clinic?
I think there are currently several people dealing with sleep, and there are several people dealing in different professions with sleep. And the concept we are trying to promote is bringing in the right people at the right level. So if you have filled out this questionnaire, which is not a questionnaire actually, this is a survey tool, and have filled out your logs and diaries, the question is with whom you are working, and it depends on the nature of, it depends on the situation. You might have a child otherwise healthy, then you will go to your GP. You might have a child as a mother of a child with autism spectrum disorder who has this, so there is an entire team, then you can discuss with the team. You might work with public health nurses, can discuss with the public health nurses or IDPs. And it's about creating awareness, discussing in which way it should go. I personally believe, and I made officially, I confessed yesterday that it took me, I think it was in Edmonton at the meeting, it took me several years, and I was working in a lot in pediatrics, to understand the tremendous dimension of occupational therapists, the tremendous dimension of the input occupational therapists can provide us. A child who has sensory processing problems will never sleep well. This has to be addressed. And I think the occupational therapists are the first partners before the GP if it is an issue of sensory processing. So we are beginning to shape this discussion. Now, coming back to your question, which was more related to the doctors, my answer is, the first part of the answer is doctors are part of this discussion, they have to be part of the discussion, but they are only part of the discussion. Other people might help more, and also reflecting sleep hygiene, sleep health measures might help more. That's the first one. The second part of the answer. The third part, very concrete, there are several GPs, several pediatricians who are very interested in this network, who are mentoring this discussion, and I think the next step will be to post the names of the mentors on the website and really begin to structure this discussion. Currently, when you ask me, it's not really transparent who is doing what. There are many pediatricians who have lots of skills and applying it in the correct way, and there are many colleagues who believe that they should refer, and there are some who think this is not important. Also, this group exists. Currently, there are 2 clinics. One is at the Children's Hospital run by the Respiratory. They have a sleep lab. They are doing a fantastic job. for the support they have received. They are increasing the number of sleep studies each year, but it's still small. They are responding to a small group of kids. I have a clinic at Children's and Sunnyhill. I had the privilege only to see kids who had neurodevelopmental disabilities, because I'm belonging to developmental pediatrics. And there is a new colleague who was trained recently in the US and came back and who is opening up a neurology-based sleep clinic. And my goal and my recommendation to the medical directors of Children's Hospital and to the ministry is that all sleep clinics come together and they get the support to work together with an occupational therapist, nurse, public health nurse, and we begin to develop together a structured approach. Unfortunately, we are not at this level. And one of the goals we are trying to achieve here is in our report to make the recommendation for that.
Thank you.
We had one further question just before we open it up about CPAP and the use in the pediatric community. I think it must have been. Pardon me, I think it was you, Jim. Could I invite you down again, please? And perhaps some of the respiratory therapists that are in the audience could help address this answer as well if you have expertise that would be pertaining. Oh, sorry, Les, I forgot that you were up there.
Sorry, I think I should give my background. I'm a pediatric physiotherapist. I was at Children's Hospital. I knew Osman through his wife for many years, and I now work in the community in the infant development program. This question was based on that parents are looking for a solution. And in that drive for a solution, I touch on Dr. Osman's, sorry, I use your first name because your last name is so hard to pronounce for me, a comment yesterday that he said that within that package that a parent brings to you, you need to tease out their desire for the one-stop, one-shop-fits-all solution and try to look for the other possible solutions. And in the particular interest of mine is Down syndrome. Many children with Down syndrome some children with Down syndrome have apnea, but I suspect they also have a disturbance in the circadian rhythms. My concern is that for parents, their one-stop is nasal CPAP without looking at the adverse effects of nasal CPAP. And in young children, particularly in the developing lung, where a positive pressure for 8 hours a night, do we know exactly what the effects of that are? We do with our children with bronchopulmonary dysplasia. We know that it can damage or negatively impact the development of the lung. We know the damage on frontal bones of a very small child. So are we offering parents a complete sleep problem assessment, or are we just moving towards this is what the parents want, this is a solution particularly popular in the States, and I just want to make sure that that's... Is that a question?
I think it is a fantastic question, and these are absolutely justified questions. What you are saying is, allow me to repeat it in my words.
Mm-hmm.
If you are convinced from something before starting doing it, are you sure or not? Reflect that. And it goes along with my understanding about melatonin. I'm absolutely convinced that melatonin helps. And I prescribe melatonin. But I prescribe melatonin under controlled circumstances and monitor what happens. And if it helps or not. And I accompany the parents. The problem is in our mandate at the quaternary healthcare service that we are not asked to monitor and follow up. So I'm doing that out of research money and donations account. So we have to monitor what we are doing. That's the first thing. The second thing is I will ask Les Matthews, who is a professor at Thomson University and leads the Provincial training program to respond to that, because he's more. What I personally believe is we have to work as a team. So I will not have the possibilities. Currently, every pediatrician or every GP can prescribe sleep. That's good. The question is who is doing the assessment, who is following up, and how. And the third question is, are there interests which lead this discussion? And for sure there are always interests. I have a conflict of interest. I believe that sleep will change. If we treat sleep, we will change some developmental diagnostic, developmental pediatric diagnosis and mental health diagnosis. And I would like to prove that. That's what drives me. Other people are driven by earning money, and I think both are legitimate interests. The question is, how can we make these interests transparent? And I am very happy to have Dr. Lori Lachenko-Cunning in the audience, sitting at the very, very back. We asked Lori to come in and help us to shape also these questions. So I think there are three now parts. One is the medical part, what is happening, the physiology-related part, Les Matthews is going to answer. One is the monitoring part, which I think we all have to discuss, because there are lots of RTs, trained RTs, whose skills can we use, how can we utilize their skills, and the third question is actually monitoring and goal setting come together, so there are two basic parts. And the third part is, of course, ethical,
The ethical side.
making it transparent. Thank you. It's a very fantastic question.
Your question about CPAP and its effects on the, yeah, go ahead. And its effects on the child's upper airway and lungs is an exceptionally good question, and I think we'll probably continue to study that as the years go on, because it's something that we need to know about. Most of the work that's been done in that area is probably done on higher pressures than what we're looking at for CPAP. Really, in a lot of ways, we're looking at a cost-benefit relationship. So if you look at 8 to 10 centimeters of water pressure to open up the airway of a child, is that going to have a negative impact on your airway? I would say we probably don't know 100% whether it will or not, but what we really need to look at is what are the possibilities of that causing damage compared to the possibilities of causing damage by not opening the airway. And I think that's really kind of what we are always looking at. So it definitely is a concern, and it's definitely something that we always need to be watching for. But at the same time, CPAP has been demonstrated to be effective especially with obstructive sleep apnea in children over and over again in many studies around the world. And so I think that it's more with children. I think the biggest problem is more compliance than anything else, and the introduction of the CPAP to the child. Because if you scare them when you first start setting it up, then you've got a long ways to travel to try and get them back to feeling okay about wearing it. And so I think that some of the work that's being done by people like Dr. Manisha Whitman's at the U of A in Edmonton, where she's been very successful setting up patients, children on CPAP, and triaging to make sure that only the ones are set up that are appropriate. I think that the work she's doing is fantastic, and we need to try and follow her lead. But I agree that it isn't a matter of just saying we should put them all on CPAP because they have Down syndrome and there's an high incidence of upper airway issues and upper airway collapse in these children. It really needs to be properly diagnosed. We need people that know what they're looking at when they're working in the sleep labs, like Ian and others that have an expertise in that area to make sure that the CPAP is being applied appropriately. The problem is in a lot of cases the resources are not there, and that's a whole different. I mean, that's kind of the elephant in the room in a lot of ways, because there really is not the funding. There isn't really the funding. The fee schedules are not there to properly apply what it is we're trying to do.
Sorry, if I could just ask, I know it's a hassle, but if people could please come down to the mic, just so that people on the webinar can fully participate in the conversation as well.
Yeah, I can't believe I'm switching my own belief systems here. In an adult population, I do not believe in surgery for the treatment of sleep apnea in many cases. But in the pediatric base, I've seen through my own experiences and through research I've done myself that the best initial thing is a tonsillectomy and adenectomy before you go on to CPAP. And with a CPAP used at a later age, under the age of 10, tonsillectomy, adenectomy is definitely a preferred method before going on to CPAP. And then after that age, if the symptoms come back or if they progress or are not alleviated, then look at the CPAP option.
Just one point on that. One of the, again, I hate to be the bearer of bad news, but there's very little OR time allotted for doing T&Es. The otolaryngologists have issues with it. There are funding issues. There are many reasons why that in and of itself becomes a bit of an issue. So it's, although I'm not disagreeing with you, I know that there is some controversy over the actual risk of surgery, the necessity of it, the regrowing of adenoids, and that all by itself is a big issue, although I understand the research you're talking about is very good and suggests that.
Yeah, our colleagues in the ENT area seem to fluctuate. It's almost like an 8-year period where for 8 years we want to take everybody's tonsils and adenoids out, and then we go another 8 years where they won't take anybody's out, and it keeps on flipping back and forth. And it's, you know, the other thing that we've got to keep in mind too, sleep in itself is a very, very young science. I was reminding someone this morning, it's only 60 years ago that Dr. DeMont first described REM sleep. So our knowledge in this area is growing exponentially, but it's still at a very infantile stage. And the more we understand, the more we start to realize, then we've got to keep our options for treatment fluctuating and willing to go back and forth.
If I can just add my 2 cents in regarding nasal CPAP and the treatment. I think I'm from Clinical Sleep Solutions, and I'm the president and CEO of Clinical Sleep Solutions, and I think I'm pretty fortunate to have an opportunity to have been working with Osman with a group of his children, and part of that initiative I felt to invest in is the ability to not look at CPAP as a means to an end in terms of treatment, and look at each patient, each child very individually. And what I've committed to is to have an open-ended, call it a trial, for these kids. And the great thing about that is we have kids that have been on nasal CPAP that we've had for maybe 7 months, 8 months, and through further assessment, through a multifaceted group of individuals, healthcare workers, they may determine at the end that it isn't the right modality of treatment long-term for the child. And I think we, as providers, have to understand that the dynamics for pediatrics is very different from adults. And if we are willing to accept that and realize that maybe the efforts are not to sell a CPAP, but really to find a solution. And if we take that perspective, it becomes an easier way to say, provide a trial for these children, see if it works, and let the groups, the powers that be, assess the whole process. Our role is simply to be the tool in which we can garner as much success as we can so that we have a proper assessment based on the application of basal CPAP. Meaning, are they able to sleep with it 4, 5, 6, 7 hours a night without interruption? What are the different things that we can do to assist with that whole process? I mean, there's so many challenges with that, but part of our role also, I think, is the importance of using these tools that we have, the app, for example, to understand that applying nasal CPAP is not all about AHI, which is, because a lot of the things when I've been discussing with the parents of these children is all about, well, how was your child today? How was your child last night? Was his sleep still interrupted? These things are more valuable tools than any number that comes out of that machine. Because first of all, yes, the machines record numbers, but you have to take it with a grain of salt. You can't, really with the children, you just can't look at those numbers. You just look at the child. And if you see, we've seen success stories where the kid would be in our office or will be in their home, and you can see the difference in the way they are, right from the get-go. And the parents will support that. But if there is no difference, what else can we do to change? Is it something that we can do in our part, or is it something that the attending physicians will be able to address? And that, I think, is where the harmonious collaboration needs to come.
Thanks, Cox, for this wonderful plaidoyer. I think we are doing pioneer work. And then coming to the core question, how are we monitoring back? I think we have to monitor what we are doing. For sure, just prescribing and saying, go home and do it is not okay. And we have to make a very clear-cut statement. Therapies have to be monitored. And we have to create evidence. We are working in an area where there are lots of black boxes. Karen showed us yesterday why it is so complex in the sleep area to move forward, because there are so many very narrow views utilizing certain hypotheses and then developed on that, and they make sense. But I can really challenge the entire ADHD medications in this province with my data. And I'm not saying that all kids are, for sure not. I'm not an idiot, I know what I'm saying. I'm saying only that I'm seeing lots of patients who have been treated for ADHD and who have been treated inappropriately because they have an underlying sleep problem. So we have to monitor, and we have to set goals, and we have to come up with a tool which makes it very interesting for decision makers to see that we are creating evidence. That's something very attractive, very sexy for them. That's one thing, and I would love to tell also something. I had a worst case scenario last year, or this year, I don't recall anymore. A young man, obese, intellectual disability, aggression, and ASD, autism spectrum disorder, and investigated by many professionals. The typical prototype of what Charles Dickens in his Pickwickian papers has described. And every healthcare professional had thought about that and wrote, obviously sleep is not a problem, because he received a sleep study. And he received a formal sleep study, I think at Royal Inlet. They nicely described the amount of disturbed sleep, and they immediately recommended CPAP. The physician who was taking care of this child thought intellectual disability, CPAP, it will not work, and didn't communicate that to the parents. So we don't have a standard how we proceed. And I'm not blaming the physician. I think we all have our preconceptions, our understandings, and we have to challenge all these preconceptions, understandings in order to see whether we are right or not. And this is now this has to be a public discussion. Parents have to be informed that there are solutions, and there are some, and they have to monitor whether it works or not. I have another patient at the age of 13 who took the first CPAP device of her father and started to treat herself because she was depressed and was obese, and all the weight loss programs didn't help her. So we are in the stage where self-medication starts. And basically with Willis-Ekman disease, restless leg syndrome, we believe that the excessive use of cannabis goes back to that. This is what I believe. I don't know if it's true or not. This is just an hypothesis. But we are hearing it from parents that who are on the condition, when they speak frankly, they say, yeah, cannabis helps me a lot, or alcohol helps me a lot. So we are at the stage of self-medication, and I think instead of waiting till getting a full, nice system with several sleep labs at several hospitals dealing in a perfect way, we will wait for the next 30 years. And I think it would be unethical to wait. So we have to make it very transparent what we are doing, why we are doing. We have to advocate, and we have to ask parents to monitor. They share the responsibility. If I prescribe a drug, and the drug, and if I prescribe it at a high dosage, and the child shows an adverse drug reaction, it is my responsibility. If I start with a very low dosage and titrate it, it is shared responsibility. I can be blamed to have prescribed the wrong medication, but also parents can be blamed if they have not picked up the first symptoms. We are collaborating. We are going in an agreement. We have a commitment. So it's about how to make this transparent. So, thank you.
So I just wanted to make one comment. It appears that the patients are obviously extremely complex, but so are the treatment methods. I think all the way from behavioral treatment and cognitive behavioral therapy, all the way through to the pharmaceuticals, to the CPAP, to there's so many, to the surgeries and so on and so forth. It's extremely complex. And I just wanted to say, Dr. Liam, who's just about to speak, he talked at our conference last March about from an orthodontic perspective, and I think there's only a handful of people in the country that are actually practicing what he's doing. And so I think it would be really interesting to have his perspective from an orthodontic perspective point of view, because it's an area, and it's an area where the literature is also very good in suggesting that there's a percentage of the population out there that do much better just looking at the structure of their upper airway and using an orthodontic approach. And so if you're not believing that, then you should maybe dig a little bit more into the literature, because it really does clearly show it as being an effective treatment in a certain patient population.
And I think this is a really important point. I know that we have a dentist in the audience that can speak to it, as well as Jennifer Garden can speak to it from an OT perspective. So I'd like to turn the conversation now to looking at how we can really rally with community partners and professionals in the community that are screening at the community level for how we can both monitor and perhaps treat at sort of that base level.
Yes. Thank you. Thank you, Les, for introducing me. That is it. CPAP is a wonderful, effective treatment that works almost immediately for adults and for children as well. However, it has so many side effects from the craniofacial development, and that's something we have to look at children. As soon as you have a pressure on the face, it will not develop properly, and that's almost the basis that they have a lifelong issue. So we really need to find something kind of different next to the CPAP as an emergency treatment, and looking to craniofacial development. Craniofacial development is really important because we are the only profession who can change the gateway of the air going into the body. By developing them forward, make them bigger, at least we control the gateway. By the way, the licensure of a dentist, it's only a part. We cannot convert it. Okay. So one of the part, it's my group job, my job, make awareness about dentists to know that they do play a role. And honestly, at this time, it's not really the case. But yes, I do believe for long term, for the health of the child, and for saving medical costs during the rest of their life, it's very important to get orthodontists really early involved in it. How early? 3-4 years. Treatment, usually active 5, 6, 7, 8 years, we do that. Most orthodontists will say, please come back when you do have your permanent teeth in. No, that's way too late. The brain development has already started and it's being delayed. So we have to start that really early. Okay. And I think if I can be part of a community that can help resources, we are only one small part, but I think we really like to be a part of the whole thing. Thank you.
Thank you.
Sure. Thank you, and I agree. I think this is such an important piece. I'd like to move the discussion to the daytime, because I think Dr. Spruyt's really mentioned a lot of the daytime pieces as well. And as an occupational therapist practicing in the community, what we do is we actually go into the home and we look at those. We observe the child, we observe the family, and if you think of it, there's the mental health components that are just so important. And I appreciate Dr. Ipsiroglu mentioning the sensory processing piece, because I think that's an integral part, not for everyone, nor is using CPAP either, right? So we have this diverse problem with sleep and all these different pieces. So it's nice to have a global perspective, and I feel that OT and perhaps the nursing pieces as well, but getting in at that community level to look at the environment, the daytime behaviors, what's happening at night, the sleep environment, the child's mental health, the parent's mental health, taking a look from that piece and a functional standpoint too. So perhaps in and looking at the daycare setting or the school setting, touching base with the teachers, and wrapping that all together to actually start to have a picture of, okay, so here are some of the issues for this child in sleep. Now, where do we want to go? And I see that as the first step, because I know, and I've been humbled by some of the physicians at some of the conferences that I've attended with Dr. Ipsiroglu, that they say it's invaluable, the physiotherapy assessment reports that they get, the speech therapy assessments, the OT assessments. We really spell out a big picture of what's going on and helps guide that primary care physician to what would be the best area. I can't order blood work, but I've certainly seen children who, the second question out of my mouth is, how are they fidgety? So tell me more about that. Oh dear, this sounds like restless legs to me. Maybe we need to, and I investigate more, and sure enough, I have them record some stuff, write up a nice little write-up, and they're off to their physician getting blood work, and oh wow, that ferritin level was 11. So, you know what? Nothing else needed here other than some of that intervention. So I think having that from that grassroots or community sense and touching base, being in the family's home, that I think is invaluable and it spells a bigger picture.
Thank you. Dr. Hall, do you have a comment further to that?
Yeah, thanks, Kirsten. I'd just like to say that I think we really need to look at this very much from a public health standpoint. And that's why I've spent so much time, and I'm so blessed to have colleagues in public health nursing who support me around the work that's been going on. The randomized controlled trial that we did, for which Osman was a co-investigator, indicated that we can get in there when we're looking at 6 to 8 month old infants and improve the severity of their sleep problems, improve their parents' mental health. So their depression scores plummeted, and we excluded parents from our study that had a pre-existing diagnosis of depression or were being treated for depression. And notwithstanding that, when we used our depression measure as a baseline, we had 41% that were scoring at the level of depressive symptomatology and 24% that were scoring at the level of clinically depressive symptomatology. So I totally understand the impact this has on family members. We all know from the literature how important it is for parents not to be depressed when they're parenting children. and what happens to the dynamics in families if they are. And we were measuring mothers and fathers. Because fathers always get left out of the picture, and they were equally as affected by these sleep problems as mothers were. So what I think is really key is situating this in public health. And that's why I've been working very closely with the Vancouver Coastal Health Authority, and together with their support, I've developed assessment tools that public health nurses can use to work out whether there's an underlying pathophysiological problem going on or whether they can see this as a behavioral sleep problem. I've worked out guides with frequently asked questions that parents ask about sleep problems for my over 10 years of clinical work with families, with about 700 families with infant sleep problems. I've recommended an intervention that the public health nurses can use, and I've provided them with a training manual. And I've done a train-the-trainer model, and I know public health nurses are out there doing that now. It also has materials incorporated that talk to parents about what is normal sleep and how do we promote healthy sleep in families. So it's not just directed at infant sleep problems. Having said that, I think we come back to that whole question of family impact and starting where the family is. So I would never recommend this for young infants before 6 months of age because they're not developmentally ready to have sleep, for want of a better word, training. That's how parents refer to it. And also, I wouldn't recommend it for families that want to co-sleep with their infants. This is not what this is about. These are families who've tried reactive co-sleeping, brought their kids into bed with them because they can't figure out any other way to have them sleep, and resent the fact that their children are in bed with them, which actually leads to family breakdown too. The only thing I would add to this is we have to be very careful about unregulated people out there who are claiming to know about sleep. So there's all kinds of people out there who put up shingles and say, I'm a sleep consultant and I'm going to charge you $500 as a family for you to come and see me, and I will tell you what you need to do for your child. I can't tell you how many times I've had to undo some of that because they've said, use sleep training for a 3-month-old or a 2.5-month-old, or they have made suggestions which are not helpful, like don't feed your baby as often during the day, breastfeed only every 4 hours because you'll make them go longer between feeds and then they'll sleep more at night. No, that doesn't work. They'll get their calories at some point and they'll get their calories during the night. So we really have to situate this in our existing healthcare system and make sure that we're not disadvantaging families who don't have money to pay for all these extra services, because these things all cost a lot of money. And that's why public health is a really good way to go, because it levels the playing field. Anybody can go see a public health nurse. They don't have to cough up $500 or $1,000 or whatever to get their children seen and cared for. And the public health nurses will refer on. But I think the problem is, where do they refer on to? And, you can do what Jennifer said, which I think is brilliant, which is, it's sort of saying, the public health nurses can say, oh, it kind of looks like there might be some restless legs going on here. I'm going to refer you to your GP or your pediatrician. But sometimes the GP or pediatrician you're referring them to doesn't know anything about sleep. And they're not going to pick up on what you've recommended needs to happen. So we have to build that capacity throughout the whole system. And I'm just focusing right now on one little piece of that system. So, and I think Julie wanted to have something.
Well, I think Wendy has actually said a lot of what I was thinking. Working at Children's Hospital, we are a center where we do assessment and referral. And I spend a lot of time trying to find services for families, and not all families can afford things. So if we've got a system, for sleep, where your only options are to go and spend this kind of money out in the community, and there's no cohesion between the public health system or no services available, I think we're in deep trouble. So I think we need to build that capacity. We're not at the U.S. Medical system. We have a universal healthcare system, and we need to have services for everybody. And I think what's really important in sleep is not to approach it from the point of view of, oh, well, I spoke to this person, I'm going to try that, or, you know, this professional was pushing this because they want to sell CPAP. You know, we see that in the States. Before trying some other modalities that may be way more appropriate. So taking this expertise here from all aspects that were discussed today, you know, the orthodontic point of view, the CPAP point of view, the respiratory, the psychological point of view, and all the rest of it, developmental disabilities, et cetera, we need to come up with some kind of an approach that is able to be individually tailored per child, but has a general kind of approach that you use. Wendy has been fantastic in terms of what she's addressed at a public health level. We hope to bring that into all workers. You know, how can we do that? How can we bring all healthcare or allied healthcare professionals that are paid for by the public health system? How do we train all those people? You know, the people that are working already for the Ministry of Child and Youth and so on. They all need to be trained with sort of a basic approach, and then we need, of course, that place to refer people. So I think there's we're at a stage where, yeah, there are some dangers because, you know, we want parents to be able to, and children to access equally across, the services, a good quality advice about sleep. Sure, yeah.
2 comments, perhaps. Number one is, I think it struck me, so my conflict of interest is I have a private practice working with exactly the children that Wendy was talking about and children with disabilities, because I found that there was nothing in the public sector and this was a need that needed to be met. Having said that, I teach at Capilano University, and I was doing an in-service at a hospital the other day, and the chief physiotherapist had a patient come up to her and hand a note saying, I need physio. And she said, well, I'm sorry, we're a 6-week wait list. You're going to have to go to a couple of clinics and see what they're like. So immediately she referred on to the private area. Most people have extended benefits, a good portion, and I would say we need to utilize those services, and that's how we can broaden access. I'm not saying that the public service sector shouldn't offer this. This is imperative. It's so important that people get the service, but we shouldn't dissuade private practice. Certainly it's a growing area and it's meeting needs that are quite frankly there. The other piece I wanted to talk about was just referrals and communication with physicians, because they are the primary caregivers. For me anyway, and as many of my OT colleagues, we write and communicate often with physicians. We do not diagnose, that's not our job, but we certainly provide a very good picture of what we've observed and to help that physician make the diagnosis or order the blood work. And I think it's by collaborating with the entire team, whether it be from private sector and public sector together, we just need to move forward in order to meet the needs of the community.
Allow me to give a comment to that. I think the conflict of interest is really coming up. You can work in a university hospital and accelerate and get some support from pharmaceutical industry in order to test a drug, and you have a conflict of interest. Or you have an incorporation as a physician and you have a conflict of interest. I think there are rules to solve that, and possibly at this point or against the end of that, I would ask Lori Dajinko-Cunning to give a comment. I think we have really to see that in a broader aspect. There is a public health aspect, for sure, which has to be highlighted, and we have to work out how we deal with the conflict of interest due to corporations or companies. There are partners, they have trained people, and most physicians have contact with corporations, so they have also a conflict of interest from that viewpoint. I think there are given guidelines, and we should possibly at the end, against the end or now, I don't know when you would like to do that, have a comment by you, Lori. That was just a...
Thank you for waiting patiently.
Okay. No, go ahead.
Please go ahead. Yeah.
Okay.
My name is Jan Palmer, and I am a behavior analyst and a resource teacher at Delta School District, and also a case manager. And so I was really lucky to be part of a team that had Dr. Ipsiroglu as part of my students' team. I work with the kids with the most challenging behavior. So they are the ones who, despite all the supports that have been put in place by the parents, by the schools, they just aren't successful. And I think that's something that has maybe been overlooked today when we're talking about communities and how to make gains for students, is that there isn't anyone from the school perspective here. And so I'm just wondering what the plans are to make sure that people like myself, who are the case managers for all these kids, for the school psychologists, who are the ones who are out doing the functional assessments in schools, who are handing out the Connors, who are making decisions, and for our school-based resource teams, who are often the ones who then sit down with parents afterwards and say, you know, we hate to say this, and we're not your doctors, but we really think your child needs more medication because we just can't, and they can't cope with the demands that are being made on them at school every day. And I think what we're seeing is more and more of those more and more of those kids are not able to be in schools, and their parents are having to find alternate methods of getting them an education.
Thank you very much for highlighting this problem. I know for myself it's a concern as a parent. We did in fact send out invitations to each one of the school districts in the Lower Mainland, and I believe that you're the only educator. Am I wrong? Do we have any other educators in the audience? I think that educators are a key component and a critical part of the screening and treatment plan. And perhaps that can move us into communication and goal setting and talking about what some of the identified gaps are in terms of partners. We've talked about using the allied partners in the community, including orthodontics, OTs.
I'll keep going.
Sorry, I thought I was being flagged there. And educators as well. And so I'd like to open up that conversation about communication and goal setting now.
So I just wanted to have a comment, Kirsten.
Thank you.
So I'm Pat Hanbury, and I'm from the Down Syndrome Research Foundation. And that was what I was hoping we were going to get to in our little group, is just discussion about what kinds of goals we could set moving forward. And I think our role is unique in the sense that we can be that conduit from information to families. And I think one key partner for us could be the Canadian Pediatric Society. And that's happened with our organization in the past. And we're quite fortunate in that the American Academy of Pediatrics has issued recommendations now in July 2011. And they have recommendations about sleep screening by polysomnogram by age 4 for children with Down syndrome. And I think for us, finding partners in the medical community who can relay that information to the Canadian Pediatric Society, develop guidelines, and then we can get that out to families.
Can I just respond to that, Kirsten?
Please.
So I just reviewed for the Canadian Sleep Society Pediatric section a document that they're going to send out as a statement about pediatric sleep. So you probably want to get hooked into that document when it comes out, because it's a really strong statement about the importance of sleep and the importance of sleep for all child groups. And I think they would be really good allies for what you're trying to accomplish.
Because really it's just, in terms of an action plan for us, it's two things. It's awareness, and then it's, Pauline raised the issue of treatment. So, but I would not say that parents would not, parents want to be made aware of the facts and the information, and then they can advocate for treatment. To keep parents in the dark because treatment is expensive or not available is wrong.
I think we have a question coming in by text.
So just a little bit of background. This is a woman who sent me an email. Her daughter is 9 years old and has GERD. So I'm just going to read it verbatim.
GERD stands for gastroesophageal reflux
disease, yeah. And very, very severe sleep problems. Please forgive me for being direct, but in my opinion, there was quite a lot of blah, blah, blah tonight. This is yesterday. I know tonight was not about personal cases, but first, where and when can we address these issues? There was a speaker talking about commercials in Australia. So true. Canadian society, and I probably see it more because I'm 50% Swedish and 50% Spanish and have grown up between two different cultures, is indeed very polite and politically correct. Sleeping challenges is a huge issue, and there's no doubt it needs to be addressed to the public. In tonight's conference, all we could hear was how to address the issue to the public. I personally wanted answers. I didn't hear anything I didn't know already. I, as many parents like me, need to know what can we do that hasn't yet been done. I've been addressing this issue to my GP. She sent me to the Jubilee Hospital here in Victoria to have an apnea test, even though she knows that my daughter is the reason that I'm not sleeping. What kind of help can we, single parents that are working and when the day ends are as tired or more than other typical parents, but still have to wait until 11 or 11:30 p.m. when the pump is finished with the night feed before we can get to bed? How do we survive to wake up the next day and do it all over again, day after day, week after week, month after month, year after year? That's my question.
I think it comes back to me because I'm proposing here a different approach to medical disorders. I don't think that there is a quick answer, first of all. The child needs a functional assessment, and the question is, what are the causes which affect which functions? And then you can come up with a solution. So obviously she has a long story and has not been heard. And it starts here with advocacy. That means using a log and diary in order to collect reproducible information and to exceed the current barriers she's experiencing. She's obviously not listened as the problems are coming in a big package and it's not clear how to approach it. We have to begin to chunk it down. And the entire app, as well as functional assessment concept with bears and to what degree it affects. If she goes and says it is a bedtime issue, the child is not able to fall asleep because of the pump and because of this and that. I'm at the end with my energy, and the child gets up in this situation in the morning, then the system will begin to re-evaluate their own mechanisms and speak possibly about respite. So respites are gone. There are many ways. We are living in a very well organized healthcare system. I have to say that despite being very critical with this system, and it offers support to people who are quite desperate, but it has to be communicated. And it has to be communicated in a way that it is heard. And the entire night we discussed that, yes, not the entire night, we are discussing it today. Yesterday night we presented the background. That would be my answer, and most happy to counsel her for sure from my clinic, and the email of the clinic is sleepassessments@phsa.ca, so write that back, and we are most happy to send her the tools and assist her in guiding, assist her in finding her way through the system.
I would like to, as a little bit of an outsider, maybe my brain just woke up, but from everything I've heard and everything I've seen whenever I travel, I think that if there's one statement that we need to make is, a child's sleep problem is, not only a problem of the child, it is first of all a problem of the family, and then it's also a problem of the society. And in society, I mean every little single piece of it. It can be employer, the pharmaceutical companies, ministry, the parent, every single aspect of it. So we cannot overlook these three elements in it. And I think in terms of getting funding for sleep research and getting sleep research in the spotlight in the daytime, it actually means that we, and that's my tip towards the parents or parent organizations with children with atypical development, is don't only put your child's sleep problem in front of it, but hook up your own parental sleep problem to it. Then it becomes also a problem of the adult sleep world, adult sleep research, which has a little bit more money and has a little bit more researchers involved than the pediatric one. And I think if you can bring that up, hook yourself up to your parental problems, to the children's problems, then it also becomes clear at the societal level. And I think eventually it will create a wave. And that wave will eventually be heard higher up at the policy level to create an answer to that wave of important groups, our future children, as well as you being currently economically important, being sleep deprived, which you need to perform optimally during the day. And as I said yesterday, you don't need sleep researchers to tell you how important sleep is. You know it by yourself when you have not slept properly the night before. And if it goes continuously like this, then you know you're in trouble. And then that's what you hear. People don't know where to go. And I think only when you hook up your own problems to your child's sleep problems, and then go with that to your physicians, to your bosses, to the schools, you know, and you just create a wave that eventually will be heard.
Dr. Hall, I know you and I were having a conversation before we started about when parents are under stress and so sleep deprived, their ability to access support and to hear information. Could you provide a comment just on the sort of deficits that parents are working with, like the parent that emailed us, and their struggle to actually access support or to fill out a log or to reach out as an advocate for their child when they're under distress?
Yeah, thanks, Kirsten. It's what Julie was talking about last night. If your sleep is constantly interrupted. I mean, I'm working with a mom right now with a 6.5-month-old, and her kid was waking up every hour to every 2 hours every night. And, you know, we just had our 4th email exchange where I am ending up having to reiterate the comments that we made with one another again and again, because it's really hard for her to process that information because she's so sleep deprived. And so that support is so necessary, that ongoing support, and not just, you know, providing somebody with information about what they can do, but monitoring what happens and providing an ongoing support. And that's why the work that Jennifer's doing is so important, because she's situating herself in the families, and then she's monitoring what's going on. And I think we really need to figure out how to embed that in the system so that we can see whether we're providing adequate support for families, for them to process what they need to make decisions. And what I'd like to do, actually, is now that we've moved this intervention into public health, I would like to conduct an evaluation study so we can see in the real world, is this intervention working? Because when you do a randomized controlled trial, it's not the real world. It's this very particular kind of set of circumstances that you set up, and you don't know how that information is going to translate into the real world. So I would like to look at kids' sleep severity measures and parents' depression and parents' cognitions, and see whether we're actually making a difference with the public health nurses working with them. So as Osman was saying earlier, we're actually monitoring what we're doing, and we're not just putting things out there and then not seeing, because maybe even with doing that, we're not providing families with adequate support, and maybe there needs to be more done to be there for them.
Thank you. Did you want to comment on that?
Yeah, and I think, thanks Wendy for those comments, and I really believe it's true, and how we set up everything and how I visualize sleep, and it's actually just thanks to my training as an OT, because it's a master's level training now, and we we have to prove ourselves because we have to be evidence-based. And so certainly everything we've done is we set up the goals and the families drive the goals, albeit it needs some education behind it, because when you do get the phone call from the parent of a 3-month-old expecting them to sleep 10 hours at night, we have a discussion about how, what milestones are appropriate. So number one, we work with families. They have a pre and a post, and we actually were able to present the effectiveness of OT based on that measure, the Canadian measure of occupational performance, where children, those goals are measured as a pre and a post. And the other thing we've recently started to do, which I really think should be perhaps done more, is the Epworth Sleepiness Scale. Simple, 8 questions, even if you're sleep deprived, you can get through it, and it astounds me. I've had parents, the cut score is 10, the higher you are, the higher your sleepiness, daytime level is, 18, and after intervention, 3. So it speaks volumes, it's quick, it's fast, and I really like the polar bears in order to screen for it, but I think we need measures to say, hey, you know what, we've been effective in our treatment, and here's what we've done. The here's what we've done is massive, right? It can be speaking to the dentist, it can be speaking to a respiratory therapist, it can nursing. We have to pull in and know where the pieces of that puzzle are in order to be effective. But I really think the outcome measures are really important in order to justify to the ministry, what we're doing really is working.
And just a comment on the question that came up on by text. I think it's important to understand, and touching also on what Ian mentioned, is that sleep medicine is infant, and pediatric, pardon the pun, is even more infant pediatric sleep medicine. So there is going to be a lot of frustration, and there are already parents out there that are almost in a desperate state. But I think this forum that we have today is perfect evidence that we are progressing. And I think even if we started off with just the group that we have today and saying, well, if we can find a way to collaborate, and not just the people up here, but everybody in the community, and do something in a small scale, I think at some point that will create the momentum. And yes, the frustration may be there for 1 year, 2 years, 3 years down the line, but hopefully that frustration is less, because there are going to be resources. There's going to be companies like myself who may refer on to Jennifer and say, hey, you got to help me with this. That's not my line of expertise. And then go into the public nurses and say that's not their line of expertise, and then go back to the physician. And then we have a full circle that we can work around. But if we just isolate ourselves, it's not going to work. But this is the perfect example of why this works, because we're talking about it today. And as long as we go along that path, I think we're already at a healthy footing for a better future for pediatric sleep.
I would like to make a first wrap-up comment, if you allow me.
Can I just make one comment before you do?
Of course.
And that is that I forgot to mention that I am part of a national team. It's a team that's across Canada. It has physicians, psychologists, nurses, Manisha Whitman is involved from U of A. And we're developing an online intervention for behavioral sleep problems for children between the ages of 1 to 10. And we're hoping to launch that in a randomized controlled trial format in April of 2014. So there are activities going on across the country. People are trying to raise the profile, and we are trying to really standardize some of the interventions that are out there and offer them to children at least up until the age of 10. This is healthy children, but it's one step in the right direction. So I just wanted to mention that.
I think this is very, very important, because all provinces and people from various provinces and territories came together and developed it. And this is a kind of really tool which can be used in a public health concept. So, and the group is now proceeding also developing how these two can be used in kids with special needs. So my first wrap-up comment would be, there is a Latin saying, divide et rule. And when we started this discussion, we were coached by a core decision maker who said, guys, you have to bring all stakeholders together. Otherwise, you will not move forward. So we are bringing all stakeholders together, and what we are discussing here is there are many ways which would lead to a solution, but it's unclear who is starting at what level. We need a better description of the start situation, and then we have to monitor what we are doing. We have to do outcome research, and then coming back using all the attendance scale. There are professions who already use it. It comes from occupational therapy. We adapted it for our clinical purposes. There are big hospitals working on the goal attainment scale. We have to create evidence of that, what we are doing, and we have to monitor. And I think key in our recommendation will be that it has to be described what is done, and then there must be a kind of monitoring. Without monitoring, it would be inappropriate to make monitoring and outcome measures. Now the question comes up, and I know how discussions then proceed. Wonderful. Please proceed, go to CIHR, ask for money. And I don't think that it is appropriate at this stage to come back with these very mentoring recommendations. I believe this money for doing outcome research has to come from the health authorities. They have to provide their people who work for them with the tools in order to monitor what they are doing. Currently, when we are speaking about the elephant and the blind man, we are the blind working with the sleep elephant, and as long as nobody sues the government, sues health authorities, everything is fine. And we are coming up with a suggestion how such a court case could be actually prevented. And I don't know, Kirsten, to what degree you are familiar with the story of ACT. I assume a lot, and whether you would like to make a comment about how ACT, Autism Community Training, succeeded. But I think possibly to see it from a broader perspective and speaking about also the obligations of the system in order to help us to be not the blind in the room will help a lot. I don't know if you would like to make a comment to that or not. But that would be my understanding, and at least I think we have to argue in our paper, in our recommendations with this thought.
I think with our organization's experience of working with the ministry, if you don't put something concrete down and present it to them, they won't do it. So we really have to come up with a strategy, like either how you do it in school, put it in the health and career curriculum, and how you approach the Ministry of Children and Family, put something like sleep awareness kids package, or put something concrete down and present it to the ministry. Then they'll take, how much do you need? How much money do you need? Then you can process. Because now we're talking, I think we're doing a lot of different things in different areas, but we need to condense it, put it together. That's just, according to my experience working with the ministry.
It's a fantastic answer. Wendy and Jen, do we have, and Julie, do we have the tools to put it together and say we are proposing in this and this and this areas the following steps? Do we have the tools? I believe yes. And yeah, I'm asking, and I think we have to, we are developing a steering committee here, how we are going to present this paper, and would you be, the question is to would you be willing to really work on this public health aspect and come up with a few suggestions, given the network you are involved in, and given the community-based occupational therapy and sensory processing pain dimension, and given the dimension of course, that everything is seen currently. Initially we had the trend to medications, now we have the trend to behavioral interventions, and second generation antipsychotics. So coming in from one group, I have the group of pharmacologists behind me, so we could really create a kind of mini task force in order to highlight what could be done in British Columbia.
Yeah, I mean, I'm totally behind that. I think that the issue we're going to have is I didn't just present the materials today for coastal health. I also had some nurses who came in from Fraser Health. But what happened in Fraser Health was there was a kind of complete reorganization of the system, and they had this new charting system coming online. So even though the nurses were really interested in it, it kind of got wiped off the table by virtue of the other things that were happening in the world and the priorities that were going on. So, you know, I think there's the potential to move this out to all the health authorities across the province, but they need to see it as a priority. And I think I've been able to be pretty effective with Vancouver Coastal Health around that, but I'm not sure how to approach the health authorities around the province to try and bring them on side with this.
I would come back to Pat's question about the school boards. We invited them. They didn't come, for sure. They have lots of on their plate, and they have not to come for a kick-off discussion. But as soon as we work that out, we should go to them back and say, this is what we are going to suggest. Who in your system would be interested in working with us, and how would you like certain things to be presented? What would be your input? So I think before going to the ministry, we have to go again to all the institutions who have an existential interest in this area and ask them for finding partners. And then this is work, and the question is, I know, and I'm thinking of the problems I might get with your husband when I become with new work for you, but I think we have really to shape that. We have to come up with a suggestion. We have to go back to the institutions, ask them whether they have an input, what they see as applicable or not. And if they don't participate, this is what I heard from Christine, we have to come up with a concrete suggestion. And if they don't participate, then we can say, unfortunately, they didn't respond. There must be also a list of those who have been asked and who have not responded.
Yeah. What are you going to do, shame them? I mean, I don't know.
Yeah, stop shame. Let's stop shame. Speak about. Tell your story. Stop shame. And I think there is a tremendous shame, and people are so much overwhelmed that we have also to communicate what the consequences of the issue is.
Yes, but I think I don't know if this is working. I don't know if that is an approach that, you know, when people are feeling threatened in the health authority, you know, that they're going to be exposed for not treating this.
Okay, I'm hearing the behavioral therapist, and I will behave.
It's a little bit dangerous, but I think if we have to look at models that have worked. I'm thinking in the link between academia and the school system. I'm sure most of you who ever had kids in elementary school have heard of the Roots of Empathy program, Kimberly Short-Rico, and that has been a very successful program where, and you know, when you it's a little more esoteric than sleep, which is a very concrete thing. Roots of Empathy is a program where somebody takes a baby into the classroom, and children who don't have young siblings, because we have smaller families now, learn about babies and development, and they also learn about empathy. And so the teacher has a curriculum. There's curriculum for anything from preschool up to sort of middle school, and it teaches, and they've done outcome measures as well, showing that this program in the school where the mother comes in every 6 weeks or whatever, and the children love the baby, they see how the baby grows. Oh, well, now the baby is teething, now the baby is sleeping through the night, now the baby is walking, da 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 da. All, you know, I think it's it's really exciting program. Kimberly has been invited by the Dalai Lama to speak in various, hot, very big conferences and had a lot of publicity. But the school has really taken up her program, and they have found that children become more empathetic after they are exposed to those programs, because one of the questions is, well, the baby is crying. Why is the baby crying? Hungry, wet, and so on. How does the mother feel? So it's teaching children to theory of mind, being empathetic, thinking of others and what they might be thinking and so on. So, there's a good example of an academic. She's in the Department of Education at UBC, who's been very successful in linking the schools. But the schools, you have to have pilot projects. You have to go through the proper, channel, the proper sort of order of things. She's got, large groups of graduate students who work under her that have linked with the schools and are collecting data and going into the schools. They've consolidated their curriculum, which is you can download it, you need to get training in it, and then you bring it into a school. It's very well organized.
I think I have to add to that something. I'm hearing you, and I would be afraid to hear one of the ideas, do these 3 studies, and then we will discuss again. That's the ongoing content of the ongoing tenor of the discussion. So I think what we have to do is we have to come up with a master plan related to public health, and then show which kind of concepts would be possible, and then find the partners who could monitor and evaluate the various steps, and the strategic partners, so that and they can go for funding. We are going to NeuroDefNet for funding. We can try to find research money, but just sending back you to your office and saying, organize research money, prove that this is the current attitude, and this will not work anymore. Again, when I see my patients, how many of them are inappropriately medicated, I'm very concerned. And I have to express my concerns in a very clear-cut statement. And then, if I do that, we have to come up with a model. Otherwise, it is just a pharmacology-focused approach. You should not give this medication, give that medication, and that's not the point. So my point is, let us develop this concept, focus on public health, let us focus on strategic partners who can help us to evaluate and to monitor certain parts in order to see what adds value or not. And that's a fantastic suggestion again. And then see how we can move it forward.
I'm just mindful that it is 11:25, and I'm sure lots of us have places that we need to be rushing off to. So if I could ask the final 2 speakers to keep it brief, and then we'll have some wrap-up thoughts.
Okay, I'm a respiratory therapist, so I'm going to take this from a respiratory, sleep disorder, breathing disorder standpoint. I agree that sleep disorders is a public health issue, but if you look at the impact of the research that's been done on adult sleep disorders and the impact on healthcare utilization, motor vehicle accidents, where it's so far ahead of where we are with the pediatric population, and the amount of funding going to the adult population on a strictly using the argument of public health is minuscule. It has been ineffective. So I think it is important, if you are going to decide how you're going to present it to the ministry or to a health authority, it can't be broad. It can't be, well, this would be the implications on healthcare utilization, or you have to choose something that's very concrete, as it was mentioned earlier. It can't be broad, because you are so far behind the adult population, and they can't get the money. So that's all I would like to say on that. The last thing I would like to say is that you can't also just think of this as a Lower Mainland issue. It's a provincial issue. It can't be a myopic sort of, this will work for the Lower Mainland. The lady that sent in her email is in Victoria. There's going to be somebody in Prince George. There's going to be somebody in Kamloops. It's got to be something that can be utilized and be implemented on a broader scale. So that's all I want to say.
The other thing that has been ongoing with regards to sleep is it's a societal issue completely. Society today has undervalued sleep to such an extent where we hold up as the norm, as the goal we all want to attain as the guy who gets by on 4 hours sleep every night. There's very, very few people in this world who get by on 4 hours sleep every night. The National Sleep Foundation, the last sort of project that they did on the length of time that we're all sleeping, showed that since the invention of these things over our heads about 120 years ago, we're all sleeping on average 2 hours less per night. We all know the human body doesn't evolve that quickly to change within the environment. So one of the areas that we also need to start going after is changing society's view on the values of sleep. And until we do that, we're not going to get the funding that we need to look after people's sleep issues. So it's a huge, like sleep itself is a huge broad spectrum problem, and we need to go after it on multi areas. And I think one of the big ones is changing society's views on sleep, and how do we go about it? That's the $64,000 question. The model I go back to is look at drunk driving. In the 60s, nobody cared about somebody getting drunk going behind the wheel of a car. We've changed society's views on that with groups like MAD, etc. Follow their models and start utilizing that to get people to start to understand the importance of sleep and what lack of sleep does to our basic overall health. Not just in the pediatric population, not in just people with syndromes and other healthcare issues, but right across the broad spectrum.
It's about changing the culture, and James Reynolds said in the evening we have to find some champions and who support the idea. For example, Kanak guys who say, if I don't sleep well, I don't score well. And something like that, it's about finding also some partners.
I think the curriculum in the schools is a big factor as well. I think there's still an awful lot of health professions that have very little, if any, base curriculum on sleep. And I think even if you look at the existing professions, you'll find that if they do have any curriculum, base curriculum, that it's recent. They haven't been doing it for very long. And so when you stop and think about all the professionals that are out there already, they've had really no training in sleep whatsoever, zero. And so why should we be surprised when you send someone to a specialist or to anyone and they avoid treating it? They avoid asking questions about it because, quite frankly, they don't know anything about it. And that's not being rude, or it's just a fact of life. And I think that's oftentimes where a problem comes from. So there's so many ways that we need to come at this, from the public point of view, from the schools, professionally, trying to make sure that all of the professions have a good core portion of the curriculum that deals with sleep and sleep issues. If we don't do that, then we're constantly going to be playing hot potato with these patients, because that's just the way it'll be. That's human nature.
I think that I'll ask that this is the last comment.
Thank you. I just wanted to say that I'm really struck by all of the expertise in the room from many disciplines, and I'm wondering if it might be an idea to create something like a steering group where you put forward a proposal for a pilot project to the ministry, where everybody is represented in the group, because you do need that evidence-based information to get money these days. The facts talk. I just wanted to say that. Thank you.
You are hitting the nail.
Yes. You stole our conclusion. Further to that is our goal. We would like to develop a steering committee, and would like to invite the audience, and in particular the commenters, to join us in that endeavor. So please approach myself or Osman, and express your interest. We really value your input, and we cannot do it without a multidisciplinary approach. The Children's Sleep Network feels very strongly about that. By way of conclusion, I just want to offer a personal remark. Emmy has struggled with feelings of loneliness and shame about sleep, and she says to me, "Mom, why is nobody talking about sleep? Why is nobody talking about me?" She sees other kids with other neurodevelopmental disabilities, awareness and understanding and appreciation. So I'd like to offer a very heartfelt thank you as Emmy's mom for talking about it and for bringing awareness to it. It means a great deal to her and to our family. So thank you very much.
Possibly let us go back to the steering committee idea. What I'm hearing is we need a public health concept, and I would be delighted if Wendy, Ho, and Jim Garden could help us to shape it to a certain degree, given your background, knowledge, work, and areas. And I would be delighted, Julie, if you could join this duo. We will try to support you with some infrastructure as much as possible, and it's about actually what we are doing is working out 3 to 4 paragraphs which conclude some suggestions other groups have done and adapting it to our purposes. That's the first step for sending out the proposal and picking up people from where they are. We as a team will begin to brainstorm and address people who could be champions for this, and Kanak players, possibly Ben Hepner, I'm an opera lover, Ben Hepner and other people, to what degree they would be interested in spearheading such a campaign, which might be a new role model, which might be a concept, highlight sleep. And we will try to find people, and please help us if you know some prominent guys who could support us. That's part of it we can integrate. We will, and that's my basic background, and focus on this communication tool and try to optimize it and develop some pre-test concepts. And we have already discussed that yesterday, today, Laurie Eisenhower had to leave and go to the Ottawa conference to test with her group, and we would be delighted if some of the parent initiative service organizations help us in testing to what degree it works, what kind of changes we need to do for our app, and continue this project. NeuroDevNet, of course, I'm a researcher and I'm not looking for public funding, I'm looking for some research funding. We are in a proposal with a fantastic review at the second stage, and I think the support of the parent initiatives may help us, and this kind of in-kind contribution really to get the feedback from research. These are the 2 major dimensions I am seeing: creating evidence, monitoring, following up, and not leaving alone. Unfortunately, Laurie had to leave, and as a very modest person, she didn't immediately step in. We had the discussion yesterday briefly about the conflicts of interest. I think we need a group who's come together and speak about conflicts of interest. And I would be most delighted if Laurie could spearhead that, and possibly we ask Les Matthews, and we ask the Down Syndrome Research Foundation as a advocacy group representing one of the core populations who have evidence-based apnea, hypopnea, and who profit from therapy, and bringing in what kind of hurdles we see. There are enough guidelines, but I think we have to reformulate it. And they say everybody is a conflict of interest. I have it as a researcher, and the pharma companies have it as industry. CLAB companies have it as mini industry, macro level industry partners, and we have doctors have it with their incorporations, OTs have it with their incorporations, behavioral therapists have it, and so with their behavioral interventions, and of course autism cognitive training has it with their, because they are trying to continue this work. So coming together and discussing how to do that, we have to shape that a little bit more, and we would love to have the input, of course, of one or two companies there, and I would love to have the input of Les Matthews and Ian, if you could take the time, also as the father of a girl with Down syndrome, whom you put on CPAP, and a critical RT, that would be something I believe tremendous. We would come up, I assume, till the Sleep Science Conference of which Les organizes. We have the deadline for me would be to have it in March for presenting. So we have to develop a kind of plan, timetable, and we can have later on a smaller session, smaller groups discussed how to utilize or orchestrate, operationalize this entire project. But then, and we are most happy to support it with not existing money from our research budget up to a certain degree, and I think at some point we have to discuss whether we also go for donations and ask for donations, and we see Children's Hospitals Foundation as well as the UBC Foundation would be happy to support that. We can negotiate what kind of money we could get, which can be doubled, and really devoted to this project, to the development of the project, and I'm not suggesting to support that the donations go all to my research account. I think the steering committee will decide then how to do that. That would be my suggestion, and wrap up. Possibly I missed one or two points, because as you heard, I have a conflict of interest.
That was perfect timing.
Absolutely. So that was the start of Be Happy, Don't Worry music, I assume. Be Happy, Don't Worry.
No, more like in another direction.
I would just like to make one sort of comment at the end of all this. I think that it's really important that we all see this as a public health issue, because it is. But then so is dentistry, and it remains marginalized from the medical system. And so I think what we need to continue to think of it as a public health issue, but we also need to embrace the private sector, because they really are the ones that are supporting the sleep industry and making things happen at this point in time. The vast majority of work that's being done within the sleep area is being done by people in the private sector. And so we need to embrace that. And yes, we probably do need clinical practice guidelines and standards of practice. And yes, we do need to look closely at how things are being done. But we also have to realize that that group of people are the ones that have maintained and have developed the adult world. And that group is really, they're probably going to be the group that are going to also do that for the pediatric world. So we need to make sure, as I think that most of the public institutions today are trying to strengthen their partnerships with the private industry and with the private sector. And I think we should follow that same frame, where our relationships become stronger and we develop better understandings of what we're doing and how we're doing it and why we're doing it within both of those sectors, so that we do not marginalize from either perspective. I think the patients will be much better off if we work cooperatively.
Thank you, Les. Can I ask, did anybody else on the panel like to make a concluding remark or last thoughts? just want to say thank you for organizing this, Osman and Kirsten. You've done a great job.
Thank you.
I think this has been a fantastic, not first step because we've been down this road for a while, but it's lovely. So thank you, everybody.
Thank you. I would really love to thank Kirsten, my Berger, Duncan Wong, and Kelsey Timner from my team for supporting that and providing the infrastructural work. Kelsey for the interviews. The project has been supported by the Rare Disease Foundation, and I would like to thank them. Karen's scholarship has been given by Peter Wu Institute for applied for advanced studies, and I would like to thank, of course, Peter Wu Institute. I would like to thank NeuroDefNet when we came up with the concept of the app. I think within 1 hour, almost all NeuroDefNet decision makers dropped by at our booth at the last FASD conference and then came up and suggested that they could support us with the data collection, and I believe that this is becoming a very, very exciting collaboration with the bigger national network, focusing from different aspects on kids' developing brain. And what we have decided today is actually to start with the steering committee, the public discussion, and develop a paper which is not the paper of Children's Hospital, of one researcher, but it will be the paper with your help of, I hope, also of educationalists, and a collaborative paper bringing also stakeholders around the table. My team members, whose one of the first jobs is to correct my English, and you see that they are not a strong team, told me that I shouldn't use the word bringing around the table, and then I accepted that I can use the term if I put it in apostrophes. So I'm putting it in apostrophes, fine, in order to please you, and we are bringing all people together. We are trying to bring all people together. Please support that. Please give your email if you are interested in supporting that, and fight with us. It's true, I think it is a few minutes before 12, literally, and we have to move forward if we want to stop inappropriate medications, if we want to stop missed pain and discomfort which leads to insomnia. And we have once more to recall the numbers. Insomnia is the major sleep disorder, not sleep disordered breathing, and insomnia is up to 80% of kids with neurodevelopmental disabilities suffer among insomnia, in contrast, in comparison to 30% of normally developing children. Usually in normally developing children, this is a transient issue, it goes over. In kids with neurodevelopmental disabilities, it is chronic, it is seen as a cause of the underlying disorder. And I love Ian's story that his daughter with Down syndrome and CBAP, obviously also not at the highest end of the Down syndrome, managed to go to, and with the support of CBAP and optimized breathing, managed to go to the college. And I think this is, we need also success stories. And if you allow me, when we get interview requests, I will, if you allow me, that give you email and ask the lady from the Gumasan to interview you. We need success stories in order to show that this is not, this is achievable. Thank you all for coming, spending such a good morning with us.